some revision go. So hope you guys had time to go through the other recorded lecture of um the theory part, right? So most of it is based around that. Let's start off the first question. Ruth is 70 years of age, has presented to your office with a complaint of muscle weakness for the past couple of weeks. She has hypertension and coronary artery disease, which she is on ramipril and atorvastatin. Physical examination is remarkable for bilateral shoulder girdle, weakness, and tenderness. So here there are some things like from the lecture we spoke about last time. One is the age. Age is 70 years. So she's above 50 years, having some weakness, some pain, and then they mention shoulder girdle as well. So when they're talking about shoulder girdle, you need to think about could it be a bony thing, right? Uh, and then they've also mentioned this. Uh, she's on ramipril and atorvastatin. So they've brought in a lot of things. So you start thinking like, what could this, diagnosis be, right? So it could be a statin-induced myositis because of this, right? Or because they're saying muscle weakness, you might think of polymyositis or dermatomyositis. And here they're talking about shoulder girdle. So then you're thinking of polymyalgia rheumatica, right? So then you order blood tests, which is significant for an elevated ESR of 48 and normal CK, normal creatinine kinase. So which of the following is the most likely diagnosis? So anyone who can go? If you all were following the lecture last time, this would be easy. There's a table with all the investigations. And if you can recall from that table, you can straight off come to the diagnosis. You don't have to go through that whole exclusion thing. So we'll just have a look. So according to this, it could, you're thinking of polymyositis because they're complaining of a muscle weakness. She's above 50 years of age. It could be statin-induced myositis, again, weakness over 70 years on ramipril, atorvastatin. So uh, it could be drug-induced, right? Dermatomyositis, we can exclude it from the question itself because they don't give us any skin manifestations, right? So it could be adhesive capsulitis again, but they don't mention any decreased range of movement or stiffness or anything. But okay, we keep that as a question. And polymyalgia rheumatica. So here, when you look at the investigations, they're talking about an ESR of 48 and the creatinine kinase is normal. So just let's have a look. Y'all are free to talk, free to ask questions, stop me. It would be good if you all can also join in the discussion, yeah. So this is the just put it as a slideshow. This is the table, right? So you can see the table, I suppose, ESR, CRP, and creatinine kinase. So they said ESR is elevated and creatinine kinase is normal. So the only two cases where you get a normal creatinine kinase is adhesive capsulitis and polymyalgia rheumatica, but ESR is above 40. That is, according to our question, it was 48. So it only matches polymyalgia rheumatica, right? So in the first three, if you take the polymyositis, dermatomyositis, and the statin-induced, all three types of myositis, if you remember it like that, all of these are different forms of myositis, right? Myositis. All of them, everything is increased. ESR, CRP, and CK. right? So we did how to differentiate with all of that, right? So when you take polymyalgia rheumatica, obviously it does not involve the muscle. So because it does not involve the muscle protein is not elevated, right? So that's one way you can just remember it. And adhesive capsulitis is basically just a problem with the joint capsule, right? So there's no involvement of muscle or joint. So all the ESR is also normal because no joint involvement. There's no inflammation, and CK is also normal. So our answer here is polymyalgia rheumatica, right? So that's how you go through the exclusion, excluding all the stems, right? So anyone having any questions, please stop and ask, okay? So this is a bit of the explanation, but we've already spoken about it, right? So next question, 47-year-old woman. So I'd like somebody to come up with the answer, at least put it in the chat box. So I know where you'll stand, right? 47-year-old woman presents to your clinic with an 8-month history of right ankle swelling and pain. So here the age is 47, 8-month history. So there's quite a long history and single joint. So you need to be, while you're reading this question, at the back of your head, you need to be thinking about the monoarthritis that can occur, right? So then the patient relates that the ankle is stiff in the morning and takes over 1 hour of walking and physical activity to ease up. So there, you can sort of narrow down your diagnosis. So here, if there is morning stiffness for more than 1 hour, what does that mean? That means that it's an inflammatory type of arthritis, right? So this is an inflammatory arthritis, joint stiffness for over 1 hour in the mornings, right? No other joint is involved. On examination, she has a temperature the temperature is normal, her vital signs are normal, and the right ankle joint is swollen and has a restricted range of motion and slightly tender. So here you have a lot of DDs coming to your mind. It could be septic, or it could be rheumatoid, osteoarthritis, anything, right? But then here now we have kind of excluded the possibility of osteoarthritis because here this line says, okay, it's an inflammatory type of arthritis, right? X-ray of the right ankle and foot shows a periarticular osteopenia. So if you guys followed the lecture last time, this particular statement, periarticular osteopenia, that is see-through bones. So I shared this mnemonic for y'all to go through to remember the X-ray findings of osteoarthritis versus rheumatoid arthritis. So one of them does not have osteopenia, one of them has osteopenia, right? Narrowed joint space. So both osteoarthritis and rheumatoid arthritis both had narrowed joint space in the criteria, right? Or in the findings of the X-ray. So which one of the following could be the most likely underlying cause to this presentation, right? So if you guys are not sure of the answer also, uh, another ways you can just there'll be questions where you have probably not gone through certain topics or something. The way to go through with AMC is you start excluding. So you think, could it be a septic arthritis? Are they mentioning anything that is suggestive of septic arthritis? It's in a single joint monoarthritis, but they're giving an 8-month history, and they're not. They're saying her temperature is normal, so she doesn't have fever, right? So normally there'll be severe pain, restricted range of motion, and all of that would be definitely there. But all of these two, this 8-month history can never be septic arthritis, right? And osteomyelitis, again, uh, Generally, the age groups are different, 5 to 15 years in smaller children, but it can happen in the adults as well. Other thing is, uh, you will get some chronic history associated, and the X-ray findings are different, right? Not generally osteopenia, they have those onion ring appearance and certain callus formation around the areas of destroyed bone. So there's bony destruction as well as synthesis as well, but this bone synthesis is happening very haphazardly, right? So you get sclerosis and destruction together. Then could it be SLE? So they have not mentioned anything related to SLE here in her symptoms, right? So they would give you at least one sort of idea to say, okay, this could be SLE. And another thing with SLE is it's a non-erosive type of arthritis, and you don't get it's not a monoarthritis. So SLE is not monoarthritis, right? Rheumatoid and osteoarthritis, you're left with. So obviously it's an inflammatory type of arthritis, so it's not osteoarthritis. Other thing, osteoarthritis does not cause osteopenia. So the answer here is rheumatoid arthritis. So this is how you can come to your answer by, sort of working it out, right? But otherwise, if you have read, if the moment you see periarticular osteopenia and that there's inflammatory features, you can go for rheumatoid arthritis. So again, here they have given you the sort of picture as if it's a monoarthritis, right? So I think we discussed this last time. So stiffness more than 1 hour, you can have decreased range of motion, you can have low-grade fever, even though they gave us a normal temperature because they didn't want us to confuse with the septic arthritis, right? Because they're giving this as a monoarthritis here. And then this is the most recent criteria, right? So you can have just one joint, right? Involvement according to their recent criteria. And it's usually bilateral and symmetric. So usually bilateral symmetric, right? But doesn't mean that it always is, right? So according to, again, this is from the RACGP guideline, they mentioned that according to the 2010 criteria, symmetrical arthritis is not required, right? So you can have asymmetric presentation. Again, it does not have to be in these joints. So if you get the proximal interphalanges, the proximal interphalanges, the metacarpophalanges are the ones that are the most commonly involved, including the wrists, right? So if you look at this picture, this is rheumatoid, the around the wrist joint, and the proximal interphalanges are these, and the metacarpophalangeal joints, right? So those are the commonly involved, but does not mean that it has to be those joints all the time, right? This is just a typical presentation. So this is how they give the questions. They sometimes try to confuse you. You think that it could be some other kind of monoarthritis, but then they will definitely give you a point in the question where you can, so I didn't show this one, you can identify, you can get to the answer, right? This one. So this is the extra findings of rheumatoid arthritis and osteoarthritis. We did last in the last lecture, right? So loss, O for O, loss and less, right? So in loss, this is osteoarthritis. Both you get loss of joint space. Then osteoarthritis, you have these bony outgrowths, osteophytes, and then subchondral sclerosis. We saw the pictures last time, right? And subchondral cysts. And then rheumatoid arthritis, the second one is erosions, soft tissue swelling. So soft tissue swelling is visible on the X-ray, right? Um, and see-through bones, that is osteopenia. So periarticular osteopenia is what they're talking about. So any questions so far? I will be going into detail. So this is a bit about the septic arthritis X-ray findings here, right? You may get joint effusions and osteoporosis features, joint space, and there's bony destructions, right? So if it's really late only, you get all of this sclerosis and ankylosing. Ankylosing means fusions, right? So SLE again, arthritis is non-erosive, right? So you won't see any joint destructions because it's basically an autoimmune thing that's affected. It's a sort of an association, right? It's part of the SLE, the whole profile. You have four or less than four joint involvement in SLE, right? So y'all can literally go through this. It's all there. Uh, I'm just showing you how to work out through the questions to get to your answer, right? So that's what's needed at the exam because, uh, like it was discussed in the first lecture, you need to uh, consider that you have less than 1 minute per question, right? Even though when you think about it, you have 1.5, you have to work around like you have less than 1 minute, right? And mind you, questions are much longer than this. So these are all the questions that we have, whatever question bank you're following, everything is from recalls, right? So students who went to the exam and they come back and they try to like, give you the gist of whatever the questions they got. So it's actually difficult to remember the entire question that they give because they make it quite long, right? So they give you a lot of investigation findings, so many things in the middle, and you're sometimes not even sure if it's needed or not, right? So when you come out of the exam, it's actually hard to give the entire question. So these are all recalls from students, yeah. So here, a 58-year-old man presents to your GP clinic with a complaint of acutely painful left knee. On examination, the left knee is warm, swollen, and tender. So right up to here, you will think of probably a septic arthritis when they're saying acutely painful left knee, right? And he's afebrile. So here he doesn't have fever. So right there you will think, okay, maybe it is not septic arthritis. And the rest of the physical examination is inconclusive. Joint aspirate shows typical features of gouty arthritis, right? So here they have obviously given us the diagnosis, but most of the time diagnosis just like this will be given to us the end of the question. So you will be trying to think of the diagnosis as you go, right? Which one of the following is the most appropriate next step in management of this patient? So this thing, next step, initial treatment or the best step, right? So these are the points you have to look into in the questions. What are they asking? Are they asking the best treatment? Are they asking the next treatment, right? So over here it's obviously similar, but when you get things like uh, trauma and uh, cases of hemorrhage and stuff, you need to think about what what their line is. Are they asking you the best management? It could be maybe blood transfusion or something. What is the next management would be probably giving a fluid infusion, so something like that. So we'll do it when we're doing trauma, right? So most appropriate next step. So here you're having a patient who is having gout, and obviously this is the first time he's been diagnosed with it, right? Because they've done the joint aspirate now, and he hasn't been started on anything probably. So what is the first thing you will start on? So when we did gout in the class, we saw that gout has an acute uh, treatment profile as well as a uh, another set of treatment for the prophylaxis or maintenance, right? And each of those drugs had its own contraindications where you avoid it, right? So you need to remember that because you, as you go, you'll see that is important when answering the questions. So here, can somebody tell me what is the next step of management in a patient with gouty arthritis? So that's kind of a basic thing, no? In the chat box, A, B, C, D, or E, quick. Anybody? Or y'all can speak? Okay, good. So that is the correct answer. Yeah, C. So here, we're talking about the acute treatment, right? He has come with severe pain. Why is it we don't give aspirin because aspirin can worsen the gout, right? And then if you take prednisolone is not the next step. It's a second line treatment. It will be the next step if colchicine was contraindicated. So here there is no contraindication to colchicine, and allopurinol is the maintenance treatment, right? So that can also be started right away, right? So according to that new RSLGP guideline, you can start allopurinol during the acute phase, but here we are trying to uh, treat the acute onset of gouty arthritis. So there is colchicine, right? So if we just have a go through so that when you answer the next questions, uh, gout. So gout again, the questions they will not give you leading things like it won't show great toe and stuff. They might show joints that are not common, right? And then also these are some considerations that I put up from the guidelines. Uh, Thiazide diuretic, any form of diuretic, they generally increase the urate levels in the body. So you have to think about that if the patient's on any diuretics while you're prescribing treatment for gout, right? And then your gout treatment may not work if the patient is on furosemide because it lowers the or impairs the action of this urate lowering drugs, right? So urate lowering drugs are our colchicine, allopurinol, yeah. And then this can actually be a good thing, losartan. It lowers the serum urate, right? So acute flare treatment, first thing we would give is NSAIDs, right? So NSAIDs are one of the primary, so it's not there in the answer. There are no NSAIDs means according to the guidelines, they prefer going for either naproxen or indomethacin, right? Celecoxib is not mentioned. Celecoxib is not mentioned as part of the treatment, so we don't take that as an answer, right? And colchicine. So these two are the first line. Oral corticosteroids if you have any contraindication to the first line agent. So what are the contraindications? NSA is generally contraindicated in any chronic kidney diseases or peptic ulcer disease. So patient with those two, and then they give you the option of NSAIDs, you can't choose that, right? Then colchicine, you can start with this dose 1.2 milligrams stat and then zero point 0.6 milligrams after 6 hours, right? This whole regime can go on for 2 to 3 days if the renal function is normal, right? But if the and also they don't have any gastric adverse effects. Colchicine doesn't have, so if they're having peptic ulcer, you still can give colchicine, right? And then if they have renal impairment, you can go for uh, lower doses of colchicine. So lower doses of colchicine for those with renal impairment. So it's actually again not contraindicated in renal impairment. You still can give colchicine, but in lower doses. If they mention a dose like this, then you cannot, right? And you can otherwise go for second line. Second line is oral corticosteroids. So that is the next step in the treatments. If you cannot give either one of these, you can go for oral corticosteroids, right? And then again, allopurinol. The problem with allopurinol is uh, allopurinol hypersensitivity syndrome, right? That's one thing. And again, those with stage 4 or worse chronic kidney disease, they have reduced the starting dose, and the titration should be within longer intervals, right, than normal. So again, it's not like you cannot give allopurinol in chronic kidney disease. You can, but you start with a lower dose. Same with colchicine, right? And steroids are second line. You go for intraarticular injection only if it's single joint affected, right? If it's multiple joints, better to go for oral, right? So those are the points you remember in gout that will help you answer your questions, right? So another gout question. Laura, 56-year-old, presents to the emergency department with acutely painful left index finger shown on the photograph, right? So here again, the joint is different, right? On examination, she is afebrile and her distal interphalangeal joint of the right index finger is red, warm, extremely tender to touch, and with decreased motion due to pain. She has had 4 episodes of such incident in the past 2 years. So it's a recurrent gouty arthritis. So they have given us the diagnosis, right? She is currently on a prophylactic dose of colchicine. So it's not the treatment dose. So she has completed that and she's going on the prophylaxis dose. And also allopurinol, right? And she is a known case of long-standing hypertension controlled on hydrochlorothiazide and metoprolol. So like we saw, thiazide diuretics can increase the urate levels, right? And she is also a known case of hypertensive nephropathy. So when they say it like this, sometimes it doesn't strike you, okay, this is a kidney disease, right? So they have put it in a different way, hypertensive nephropathy. So yes, this is a kidney disease, right? So then she has a kidney disease, which means she is on very low dose of colchicine, probably. And she's also on a diuretic that will increase the urate levels in the body. So this is probably the cause of the recurrence, right? So which one of the following uh, would you consider for her as the first line treatment option at this stage? So first line, right? So what were our first line treatments? NSAIDs and colchicine, right? So NSAIDs, can we give her? No, she has kidney disease, right? So we cannot give kidneys, NSAIDs, right? So colchicine, and the other next step is going for prednisolone, right? So which one are we going? Let's look at the options, right? So here, because otherwise it would be a confusion, they have not given us the choice of colchicine. So if colchicine was there, obviously we can choose it because it's not contraindicated like we saw in kidney disease, right? But they haven't given us colchicine. So the first choice is allopurinol cessation. So that's not an option, right? You can continue allopurinol during the acute flares, right? Indomethacin contraindicated in kidney disease, right? Celecoxib is not a treatment in the guidelines, right? Then you have prednisolone for 10 days. That is one option. And increasing the dose of allopurinol. So again, allopurinol is not for acute treatment. It's the maintenance therapy, right? So our answer here is now prednisolone for 10 days, right? Was it clear so far, everybody? So here again, so I'd like one of you all to try answering this. 56-year-old presents to the emergency department with acute onset right knee pain. So here again, they've given us knee pain, right? Um, Starting 3 hours ago and worsening gradually. On examination, she has a BMI of 32, blood pressure is on the higher side, and then pulse rate is 90, temperature is normal, and joint aspirate excludes septic arthritis. So now here we have a monoarthritis, short duration, right, and worsening pain. So septic arthritis could be one of the DDs, right? So here they have excluded septic arthritis forever for us. However, the presence of birefringent crystals is highly suggestive of gouty arthritis. So they've given us the diagnosis. Her medical history is remarkable for chronic kidney disease and again that's hypertensive nephropathy, and laboratory tests are ordered for which these are the findings, right? So serum uric acid, GFR is 30, right? GFR is 30, known patient with chronic kidney. So these are the points you need to remember, right? And which one of the following is the most appropriate treatment to consider in her? So can somebody try? Can you all put it in the chat box? Yes, good. So you guys are on, have kind of got the hang of it, right? So it's D. So again, paracetamol is not a choice. With such acute pain, naproxen cannot be given CKD. These are not part of the treatments, right? You can consider, right? Allopurinol is maintenance therapy. So our treatment choice is colchicine, right? And it's not just because GFR is 30. Remember, it was not contraindicated according to the RSCGP guidelines. They said low dose, right? So we did this part as well. Um, Mary is 32 years old and 36 weeks pregnant. She has had an uneventful pregnancy to date and has attended her antenatal care regularly. At today's visit, fetal auscultations significant for bradycardia. CTG confirms a persistently decreased fetal heart rate of 67 beats per minute. So, emergency cesarean section is considered and performed. The neonate still has bradycardia at 70 beats per minute. So, which of the following antibodies are neonatal bradycardia? So, the cause of congenital heart block is uh, SLE, right? SLE, Sjogren syndromes. You get several conditions. I think we did it in the last lecture. I'll show you the slide. Which of the following antibodies is most likely to have contributed to such presentation, right? So answer, if you all have gone through the last lecture, you should be able to just put the answer in the chat box. Okay, so I think this has to be a separate one. So let's just take a look at the slide. This one. So neonatal lupus erythematosus causes 80 to 85% of the cases of severe AV block in the neonatal period, right? So presentation of cutaneous manifestations range between 7 to 16. You can get cutaneous lupus as well in the babies, right? It occurs between 7 to 16% of mothers with positive autoantibodies of anti-Rho and anti-La. So, as we know, congenital heart block can occur with anti-Rho and anti-La, right? These autoantibodies are present in 0.1 to 1.5% of healthy pregnant women, but 90% of patients with Sjogren's syndrome, 20 to 30% with SLE, and 3% with rheumatoid arthritis. So, any of these three conditions can give rise to congenital heart block in the neonate, right? So far, there is no specific epitope responsible for neonatal lupus erythematosus, but some animal models have suggested a greater role of anti-Rho. So that's what I think they are looking for, right? So in most of these researchers, what they say is anti-Rho uh, has a higher effect on the neonate than anti-La. So both of it does have an effect. Both of it leads to neonatal, the cutaneous was as well as the congenital heart block, right? Uh, but anti-Rho is the one that causes. So our answer here is A, right? Here we have a 37-year-old woman with facial rash and joint pain. So she has presented to your clinic for the first time and has a facial rash shown in the following photograph. So we can see the type of butterfly rash, right? The mallow rash, right? According to her, the rash is more prominent when she's exposed to sunlight. So that's another symptom of the butterfly rash, right? That comes with SLE. She also complains of 4 kilogram weight loss in the past 3 months, low grade fever, and fatigue. Right? She has had intermittent painful and mildly swollen wrists and knees, to which recent finger pain has been added. On examination, oral ulcers that she has never noticed before are found. You order lab tests, and the result of which are remarkable for normocytic normochromic anemia. So anemia of chronic disease, that is that with SLE, right? Thrombocytopenia and an elevated ESR of 110 with a positive ANA and positive DNA, right? Which of the following? So they have given you all the features. They haven't told you it's SLE, but when you read through this, you know, okay, they're talking about SLE, right? So she's having the typical malarash with the nasolabial folds pairing and elevated ESR, positive ANA, positive dsDNA, right? Oral ulcers and the joint involvements. So with all of that, you can come to the diagnosis, okay, this is SLE. But what they are asking is, what is the appropriate long-term treatment? So what is the treatment for SLE? She is 37 years. Uh, and she's come for the first time. So you have to go for whatever the first line treatment, right? So what's the first line treatment in SLE?
Steroids.
Sorry.
Steroids.
Yeah. So with SLE, one of the, especially in the reproductive age group, uh, the first line treatment for SLE is generally hydroxychloroquine. Yeah. So if we go through again. To do SLE before that. So again, these are the criteria we did the other day, right? Uh, it, you need four or more criteria, one clinical, one laboratory, right? So you need four, but at least one from each side, right? So she had laboratory criteria, ANA was positive, dsDNA was positive. So two right there, right? And then what else did she have? She had oral ulcers, right? And yeah, two or more joint involvement. That synovitis is the kind of arthritis that they get, right? So two or more joint involvement. Anything else? She had thrombocytopenia as well, right? And then she had this normocytic normochromic anemia, right? So Coombs test wasn't done, so we just consider that to be anemia of chronic disease. Yeah. So she had four more criteria. So we go with the diagnosis then. So I think, given the answer, hydroxychloroquine is recommended for all patients with SLE, right? So, especially when it's in the reproductive age group, uh, it can be continued during even the first trimester of pregnancy, right? So they ask them to continue it, right? So glucocorticoids is for rapid symptom relief, but the medium to long-term aim should be to minimize the daily dose to less than 7.5, right? Subsequent initiation of immunosuppressive drugs, that is, it depends on whether she's having any symptom relapses while on hydroxychloroquine, right? So these are the other second, third line drugs to consider, right? So they'll normally be asking you what are the first line. So always remember, uh, if they have poor symptom control with HCQ and glucocorticoids, you can go for these two, methotrexate and azathioprine, right? MMF can be given in both renal and non-renal SLE, but not in neuropsychiatric. So if they give you a neuropsychiatric SLE patient, uh, you can consider cyclophosphamide. So any organ-threatening disease, renal, cardiopulmonary, neuropsychiatric, you can go for cyclophosphamide, right? So this is again from their guidelines, right? So here the answer is C, right? It's hydroxychloroquine. They're just describing some features of, so you can take it from the table in the lecture that has the criteria, right? Uh, Positive ANA, positive ANC. So what is the, there's another question. I don't think I put it today. What is the most, the diagnostic test for SLE? That is anti-Smith, right? Anti-Smith antibody positive means it is diagnostic for SLE, right? It's like the gold standard test. So hydroxychloroquine is the cornerstone of treatment in all SLE patients. I think I shared the guideline on the lecture. I'm not sure. I'll just check that. Yeah, and also when you think about the side effect profile, HCQ is always better, right? It has a lower side effect profile than going for steroids and NSAIDs, right? So this is that thing that I had classified and put. If it's neuropsychiatric features or organ involvement, what do you do? If it's renal, non-renal, next step, what do you do, right? So this is just rheumatoid arthritis, just to show you all one of the styles of asking questions, right? Here it says, which one of the following is not considered an extra-articular manifestation of rheumatoid arthritis? So remember that when they're asking this kind of question, always go through the question again. Are they asking which one is or which one is not, right? Sometimes in that rush and in the stress of the exam, you miss this word not, right? And then you're looking at the choices and you're not sure which one to choose because everything looks right, right? But then when you go back to the question, they are saying which one is not, right? So here, which one is not considered a manifestation of rheumatoid arthritis? So here, the answer is hepatomegaly, right? So these things are normally seen in rheumatoid arthritis. You get Raynaud's syndrome, peripheral neuropathies, right? Nodules, and these are those soft tissue enlargements you get, right? Uh, yeah. So bony manifestations of rheumatoid arthritis, you get osteopenia, like we saw, osteoporosis can occur in the later stages. There can be joint destructions in rheumatoid arthritis. We saw that in the previous slides from the last lecture. Bony erosions, remember? So they can get osteoporosis. And the other thing is they're on corticosteroids, right? So that can also lead to osteoporosis. Then you get the rheumatoid nodules. So this is a well-known skin manifestation, right? They have several manifestations in the eye, right? And they can be associated with Sjogren's syndrome as well, right? So dry eye, dry mouth. We did that last lecture. Sjogren's syndrome, dry eye, dry mouth, right? So I'll not go through the details here. Diagnostic test in 17-year-old with blurry vision. So here, uh, let's see what they're taught. So this is again another question to show how they kind of bring in the associations, right? 70-year-old man presents with complaints of headache and blurry vision of his right eye. He also mentions a history of shoulder pain that has been bilateral and associated with morning stiffness for at least 30 minutes for the past few months. So he's having some inflammatory thing, uh, morning stiffness for at least 30 minutes, and it seems to be symmetrical, bilateral, affecting the shoulders, right? So shoulder and hip girdle, then we need to think about polymyalgia, right? Which of the following investigations is most important to establish the diagnosis? So this is a typical question they give, right? Where they don't give you the diagnosis, uh, and then they are talking about something associated with the initial diagnosis. So if you get your diagnosis right, then you can think about the association, right? And from that association that you have come to conclude, you have to find the investigation, right? So basically, they are asking three questions here, which is hidden within the question itself. They're asking you what is the diagnosis, and then what is this association happening here, and then how do you come to your what is the best investigation, right, to diagnose this. So here again, more than 50 years, right, and he has a history. So this current complaint is headache and blurred vision in the right eye, but his past history is that he has a shoulder pain, which is bilateral, associated with morning stiffness. So I said, uh, generally they show polymyositis, dermatomyositis, statin-induced myositis. Those are muscle-related. They'll tell you something about weakness and muscle involvement, right? Muscle pain and weakness. But here it's stiffness. So when you talk about stiffness, you're thinking about the joints, right? So generally they say 45 minutes, but here they're given it as 30 minutes, right? So here your diagnosis is polymyalgia rheumatica, and then now he has come with headache and blurry vision. So what do you think the condition is now? What is the condition they're talking about? Chat box at least. Somebody can speak. I've given you the background disease is polymyalgia rheumatica, right? So what is the associated disease that they're talking about here? Okay, so looks like let's go back to that slide and mm, so this is with the guidelines. Yeah. So this is the bit on polymyalgia rheumatica. You get the bilateral shoulder and hip girdle pain with stiffness, right? Generally, they say morning stiffness more than 45 minutes, right? Age more than 50 years or more, right? It can be either shoulder or hip or both. Then, so this is the background disease. You can have uh, visual loss, double vision, right? So, giant cell arteritis, the ultimate thing is blindness, right? Irreversible blindness. So, temporal artery tenderness, headache. So, he's having headache, right? And here I have highlighted it as a, oops. Uh, GCA should always be considered as a, that is giant cell arteritis, as a differential because it occurs in 16 to 21% of patients with polymyalgia rheumatica, right? So whenever GCA is suspected, thorough clinical evaluation should be performed. So this is the association we spoke about last time, right? Polymyalgia rheumatica is generally associated with giant cell arteritis in the sense that first, they get polymyalgia rheumatica. They'll have a long history of PMR, right? It always precedes giant cell arteritis, right? So giant cell arteritis can occur later, right? Thorough clinical evaluation and supported by the measurement of inflammatory markers, right? So what are the inflammatory markers we look at in GCA? It's the ESR, right? And temporal artery biopsy is the gold standard. That is the diagnostic. But what do they say? Temporal artery biopsy is going to take at least 2 weeks, right? It's a biopsy. So we should not delay the prompt institution of high dose corticosteroids if you're suspecting GCA, right? Even after giving steroids, you can do the temporal artery biopsy. You don't have to delay the time. So that is also a question, an MCQ question. I'm not sure if it was there today's slides. There's an MCQ question. They asked whether you have to delay the corticosteroids till you get the reports confirming, right? No, you give the steroids and then you can even do the temporal artery biopsy later. It doesn't change the reports, right? So this is the diagnostic criteria for GCA, right? Giant cell arteritis. ESR is more than 50 or more, right? And a positive temporal artery biopsy. So clinical diagnostic criteria is 3 out of 5, right? So this is a treatment schedule. We did it, right? So what are we going to do first? So which are the is most important to establish the diagnosis? So just look at the question. They are not asking you what is your next investigation to initiate treatment, right? They are asking you what is the most important to establish the diagnosis. So you're thinking of something that will give you the proper diagnosis. So what is the answer there? Yeah, so gold standard is temporal artery biopsy. So always read the question. So you get similar questions to similar to this. Again, giant cell arthritis questions. They will give you a background of polymyalgia rheumatica and some jaw claudication, headache, right? Blurred vision. Some come with blindness also. Then some of the questions they will ask what is the next investigation you would like to do before starting treatment. So what is it that you like to do is ESR at that point, right? So immediately what you would like to do is an ESR and then give the patient high dose steroids. But the question here is how are you going to establish your diagnosis? So establishing diagnosis is temporal artery biopsy, right? So that can be done even 1 week later after initiating steroids, right? So 73-year-old woman presents to your practice with a complaint of shoulder girdle pain. Again, shoulder pain for the past 8 months. So long-term pain. Pain is mostly felt in both shoulders. So it's bilateral, symmetrical, everything, right? Aching and vague in nature. She also has stiffness of the shoulder girdle. So stiffness is another word that you need to keep in mind. Okay, it could be PMR, right? And takes 30 to 60 minutes of physical activity, sometimes a hot bath to improve, right? So she denies any fever, weight loss, headache, or visual symptoms. So fever, weight loss is also one of the symptoms of polymyalgia rheumatica, but she doesn't have it. And then no headache or visual symptoms. What are they saying? She has no associated uh, features of giant cell arteritis, right? So if there is no giant cell arteritis, then what is your next step of management, right? Past medical history is significant for osteoporosis. So again, uh, this is also important here in when you think about the treatment. So what is the treatment for polymyalgia rheumatica? Generally, you give steroids, right? So you have to also think, okay, she has osteoporosis, right? For which she is on alendronate, supplemental calcium, and vitamin D. Laboratory tests show a normocytic normochromic anemia and ESR of 100, right? So if we look back on that PMR slide, right, we have ESR more than 40 is was one of the criteria, right, for polymyalgia rheumatica. But for giant cell arteritis, ESR was more than 50. So don't confuse that, right? So this is giant cell arteritis, that acute presentation. ESR, you're expecting more than 50. But when you're talking about polymyalgia rheumatica, they say ESR more than 40, right? And it's on this table, right? And then another thing that was also in the question, uh, morning stiffness more than 45 minutes. So they are here, they're giving you something similar, right? 30 to 60 minutes of morning stiffness. Again, age 73, right? So which one of the following is the most appropriate next step in management? So what are you going to give this patient as treatment? So generally, I mean, polymyalgia rheumatica, there's no other treatment, right? We saw treatment for polymyalgia rheumatica is steroids, Yeah. So GCA or PMR, it's steroids, right? So here, steroids are going to go on for a long time. In both cases, it's going to go on for at least 2 years, maybe. Uh, so that's why I shared. This is a universal thing anywhere in AMC where you're talking about steroids. Remember this slide, right? So you need to think of assessing her lumbar and hip spinal bone mineral density, right? So maybe she's already diagnosed osteoporosis, she's on alendronate, so she will need all of this together with the steroids, right? So it doesn't say if they have osteoporosis that steroids are contraindicated, right? They're saying if they have osteoporosis, then you need to consider the alendronate or the resonium or risedronate, and then you have to also give adequate supplementation. So she is already on all of those, right? So because she's already on this, you can definitely start her on corticosteroids, right? So rheumatology generally, uh, treatments are quite easy. Most of them treatment is steroids, and then you get the DMARDs, the monoclonal antibody or the TNF, right? That's how the line goes, right? You just remember when to give what, right? The clinical picture is highly suggestive of PMR, right? And in if both conditions are present, PMR invariably precedes GCA, right? So GCA is like a thing that comes after you have developed PMR. Um, Here they have said pain and stiffness of the shoulders and hips, right, in a symmetrical fashion. That is part of PMR, right? Cervical spine may be involved. So this details is not necessary, right? Remember, corticosteroids are recommended as the initial therapy in patients with PMR. So again, uh, painful and stiff shoulder. 76-year-old woman presents with painful and stiff shoulders that she has had for the past 2 months. So, stiffness is worse in the morning, again, improves after 30 to 60 minutes of physical activity. So, this is that more than 45 minutes, right? Stiffness in the morning, right? She denies headaches and visual problems, right? So, again, she's not giving features of giant cell arteritis, right? So, then her laboratory, what's significant here, platelet is 500, that's it, right? And then ESR is 65, CRP is positive, and rheumatoid factor is negative. So it's some seronegative thing. If rheumatoid factor is negative, we go as seronegative, right? So ESR is high, CRP is positive. Rheumatoid factor NA negative. Which of the following would you consider as a treatment for this patient? So what do you think the diagnosis is here? It fits the criteria, right? So can somebody tell me the diagnosis? Anybody? Or at least the answer? You all have to also speak. So what is your treatment here? Yeah, so prednisolone, right? So so basically what this question is doing is they are trying to make you come to the diagnosis more than asking for the answer here. They have asked two questions within this. What is the diagnosis and what is the treatment, right? So someone can answer this as well. 74-year-old woman presents to the ED with sudden onset left visual loss that occurred within a few hours. She also mentions having left-sided headaches for the past few days and hip and shoulder pain and stiffness for 7 months. So all of these symptoms together, when you think of it at once, if you haven't read through that guideline, it will seem confusing. She's having hip and shoulder pain, she's having a headache, and she's having some visual loss as well. So then it will sound a bit confusing. So if you know the guidelines, if you have gone through the theory, then you know, okay, they're talking about polymyalgia rheumatica, and then now she's having a giant cell arthritis, right? So most appropriate next step in management. y- Yes, so it's D, right? So did you see the difference between this question and the previous question? Previous question was asking you uh, sort of what will help you come to your diagnosis, right? So that was temporal artery biopsy. And here, what they're asking you is uh, most appropriate next step, right? So these are like famous sort of uh, words that are phrases that are used in AMC, right? So next step here is ESR, right? So someone can answer this as well. You are visiting a 75-year-old woman in your practice who is complaining of bilateral pain and stiffness in her shoulders and hips, so both shoulder and hip. And she complains that the pain and stiffness is worse on waking and becomes better after 40 to 60 minutes. So it's all following that criteria, right? 45 minutes of stiffness, bilateral shoulders and hips, over 50 years of age, right? On examination, there's no remarkable finding except generalized stiffness of her hip and shoulder girdles. Of the following investigations, which one would most likely to be consistent with the diagnosis? So again, your diagnosis here is PMR, right? So they're not talking about muscle weakness. They're talking about shoulder girdle stiffness, right? So if it's muscle weakness, you must think of polymyositis as well, right? But here, it's a bilateral shoulders and hips. So it's one of those criteria in that box for polymyalgia rheumatica, and stiffness more than 45 minutes. Again, a criteria for polymyalgia rheumatica, age more than 50 years. So 3 out of that 5 criteria have been covered here. So you're taking polymyalgia rheumatica, right? What if you think about that table that we have given you for the investigations? Uh, which one would you choose here? Which is most likely to be consistent with the diagnosis? So the diagnosis of PMR, right? What's the answer there? You all can speak as well. Yes, good. So here, in polymyalgia rheumatica, if you think of that table, we had one column for ESR, the other one was CK. So uh, out of those columns, we have only ESR on our choices, right? So ESR elevated means one of the features of polymyalgia rheumatica. It should be more than 40 for PMR, right? So positive rheumatoid factor, it's a seronegative arthritis. So rheumatoid factor is negative, right? Calcium is not a thing. ALP again is not considered. And joint space narrowing, decreased bone density means osteopenia. Uh, that is not suggestive of polymyalgia rheumatica, right? So this could be either rheumatoid arthritis, osteopenia, right? So yes, B is the answer there. So we'll be doing at least 20 questions. Uh, if there's anything else later on when you all are revising, if you all cannot answer, if you're not sure of the answer, it's confusing, you can always put it on that chat group and we will help you out, right? 51-year-old man presents to your practice for back pain and he was diagnosed with ankylosing spondylitis 20 years ago, right? So it's a juvenile type of arthritis, right? And he has mild back pain all the time. So remember mild back pain. And he had received no medical treatment and has been on exercise program on and off basis. So I shared the guideline last time. For ankylosing spondylitis, what they say is it's better to be on NSAIDs, at least on a low dose, because it slows the progression of uh, joint, the X-ray, any changes in the X-rays, right? So some have been diagnosed with ankylosing spondylitis before X-ray changes. To slow that progression to developing X-ray changes, NSAIDs has found to be effective, right? So, but this patient unfortunately has received no medical treatment and is on an exercise program, right? Patient suffers from peptic ulcer disease and has been treated for the condition several times. So now, what are they trying to tell you? NSAIDs are contraindicated. So NSAIDs was one of the prime choices for treatment in ankylosing spondylitis because it slows the progression of disease. But now what they are trying to tell you here is, so if you know what they're talking about, actually every sentence that they mention in the question does make some sense, right? Patient suffers from PUD, has been treated several times. Which one of the following is the most appropriate next step in your management, right? So, what are you going to give this patient? They don't really say he has any X-ray changes, right? It's just a mild back pain. For a mild back pain, what would you give? All of these points they have given are actually treatments used in ankylosing spondylitis, but certain treatments are started when they are diagnosed. It's a seronegative arthritis. Again, what you mean by seronegative is rheumatoid factor is negative. So here, what is positive is HLA-B27, right? And certain treatments they spare for those who have X-ray changes, right? So we will just go through again. Certain changes are um, certain treatments are in case of extra spinal disease. So you get this ankylosing spondylitis is mainly an axial disease, right? It involves the spine. It starts at the SI joint, it can go above, right? But some cases it involves other peripheral joints. So for peripheral joints, there's another set of drugs that have been saved. Uh, so I have divided it for y'all. If y'all can keep like a screenshot or something of this, it's good. So this is ankylosing spondylitis. Axial arthropathy. So mainly involves the spine and the side joint, right? Enthesitis, that is inflammation of the tendons where it's attaching to the ligaments where it's attaching to the bone, right? Syndesmophytes and sacroiliitis. So syndesmophytes means bony outgrowths. That is what results in the bamboo spine appearance, right? Sacroiliitis, you cannot really see it on an X-ray, but you can see it on an MRI. So soft tissue or the bony inflammations can be seen on MRIs, right? Significant back pain, morning stiffness is one of the main clinical signs. So if they give you a question where someone's coming with persistent back pain and morning stiffness, especially young patient. So third and fourth decade means in their 20s and 30s, right? Uh, this is uh, highly suspicious of ankylosing spondylitis, right? Uh, Axial spondyloarthritis primarily affects the spine and SI joints, although other joints like shoulders, hips, ribs, heels, small joints of the hands and feet can become involved, right? So night pain is also a thing you need to remember, right? It can be associated, it has some extra articular manifestations such as uveitis, inflammatory bowel disease, Crohn's disease, right? HLA-B27 positive, you have to remember this, right? So these are some extra axial features. That means not involving the spine, right? So Achilles tendonitis, ligaments, tendons, intercostal enthesitis, right? Sausage did it. So here, if you look at this, you get uniocular anterior uveitis occurs in about 40% of the patients, right? So if they give you painful red eye, in the ophthalmo section, we'll be doing painful red eye, how to identify uveitis and stuff. So that can come on a background of ankylosing spondylitis, right? Here, first line treatment. So what is your next best step if they give you a case of anterior uveitis? It's corticosteroids and mydriatic drops, right? 60% will have inflammatory changes on the colonoscopy. Of that 10% will actually have symptomatic inflammatory bowel disease, right? So again, uh, that has its own treatment set, right? So then mostly steroids, right? Osteopenia, osteoporosis, they will have increased fracture risk. Apical pulmonary fibrosis, aortic valve, all of these are associations, right? So features of inflammatory arthritis. So this is what you need to know in the management. So as you saw, most of the questions in AMC are regarding management, but they don't give you the diagnosis either. So you have to figure out the diagnosis as well, right? So just studying the management also won't help. You will need to know a bit of the criteria, the clinical features, the workups, right? So that you are able to come to the diagnosis before you answer the management question, right? So exercise here, NSAIDs are first line therapy. So this is first line therapy. Studies have suggested that regular NSAID use in ankylosing slows the radiographic progression, right? More than more than with on-demand use. So giving them regular NSAID dose, then only when there is pain. So it slows the radiographic progression. So remember that NSAIDs for ankylosing. But of course, if they have peptic ulcer disease, you can give some other painkiller, right? Depending on how severe the pain is. Then tumor necrosis factor inhibitors and other DMARDs, right? So spinal disease, methotrexate and sulfasalazine, basically DMARDs, have less effect on the spinal disease. So ankylosing spondylitis is axial, but when it's associated with peripheral arthritis like the shoulder or the wrist joints or whatever, you can use go for DMARDs, right? So remember that. Uh, if there is spinal disease, you can go for DMARDs. Sorry, if there's extra spinal, right? That is peripheral arthritis, you can go for DMARDs. And then if there is uh, associated uveitis or inflammatory bowel disease, then you can go for corticosteroids, right? And then in severe cases where there is radiographic changes, in those cases, you need to think about the next step of treatment, that is monoclonal autoimmune necrosis factors, monoclonal antibodies, infliximab, rituximab, those things, right? So this is the bamboo spine. These are the syndesmophytes where actually there should be the disc on either side. You normally don't see whitish, right? You don't see bone here. So here these are syndesmophytes. So this is what gives rise to that bamboo spine appearance, right? Fusion can occur here between the spines, right? Uh, those are some features. So here, what I was trying to show you is he has a very mild back pain, right? And he cannot take NSAIDs because he has peptic ulcer, and they haven't told you that he has any X-ray changes. So, what are you going to do here? You can give him paracetamol, right? So you're not going to go for infliximab because no X-ray changes. You are not going to go for methotrexate or sulfasalazine because they are not telling you he has other joints other than the spine, right? You can't give naproxen because he has peptic ulcer disease, so you're going for paracetamol. So if it was difficult to answer, you could have gone with this uh, exclusion of the points, right? So if that for that you should have known this theory here, right? So if you know this uh, slide, then you can answer that question, right? So first-line management is NSAIDs. Regular use of NSAIDs has shown to reduce symptoms as well as the rate in which skeletal changes occurs. This patient has been diagnosed 20 years ago, not received any medication, and has a mild low back pain. So without gastric problems, NSAIDs was the drug of choice. But with PUD and the pain is mild, you give simple analgesics, right? So methotrexate and sulfasalazine are for extraspinal manifestations, right? What they mean by extraspinal arthritis, right? So it shouldn't be uh, manifestations. Then you would think of uveitis and stuff, no? So extraspinal arthritis is methotrexate and sulfasalazine. Infliximab is a TNF inhibitor, right? For those with axial involvement with inadequate response to NSAIDs, right? Or severely progressive disease. So X-ray changes and stuff like that, right? So again, another ankylosing spondylitis. Somebody can try to answer this. 35-year-old man, again, young patient they're showing here. So did you notice that with polymyalgia rheumatica, they're all talking about those in their 60s, 70-year-old, mostly they were giving the age group of 70s. But now when they talk about ankylosing spondylitis, yeah, they have gone with the younger age group. So that also should give you a small hint, right? When you're starting to read the question. Uh, Visits a GP with severe back pain for several years. The pain is worse on waking up in the morning, and pain and stiffness make him stay in bed for at least 30 minutes. So, stiffness is more than 30 minutes, that means. So, that means it's inflammatory type. Pain ameliorates by walking and physical activity along the day, and his condition has deteriorated recently despite maximum dose of naproxen. So, here we see this patient is on maximum dose of naproxen. X-ray of his lumbosacral spine is shown in the accompanying photograph. So if you look at this X-ray, I'll just enlarge it for. This is the typical bamboo spine, right? You can see the uh, intervertebral discs are also on either side. You see the whitish lines. So these are syndesmophytes. Normally, intervertebral disc is translucent. You don't see a white line on either side, right? So that's how you kind of identify the syndesmophytes, right? And then you can see fusion, right, of the spines. So this is a ankylosing spondylitis with radiographic changes, right? And not responding to NSAIDs. So what is the most appropriate, again, next step in management? What would you do here? So let's try to just exclude, right? Uh, these two we're giving only when? So when there's extra spinal disease, we give A and B when there's extra spinal arthritis, right? Aspirin is not part of the treatment in ankylosing spondylitis. Prednisolone is given when you have extra articular features, that is uveitis, inflammatory bowel disease, and all these other uh, things that can occur with ankylosing spondylitis, right? So Crohn's disease, right? So what is our therapy here? So if we, I mean, just the last slide itself, we mentioned infliximab. Anything with mab. Mab means mab stands for monoclonal antibody, right? So these are tumor necrotizing factors, right? Infliximab is an inhibitor approved for use in patients with axial involvement with inadequate response to maximum dose of NSAIDs or with severely progressive disease. So this patient has both. He has inadequate response plus you can see the X-ray has changes, right? So this is also another, you don't have to remember the name of this drug. Actually, I didn't go through with these drugs. Just remember if it ends with MAB, it's a monoclonal antibody, right? So this is a MAB, you need MAB therapy here, right? So it's your option C, right? So yeah, we have a few more slides up. I'll give you all like a 15-minute break. We'll join again at 7 and we'll continue with the rest of the slides. Yeah. Yeah. We'll join at 7, okay? Okay, so let's move on with the rest of the questions. So I would like you all also try and answer these questions. So then it will just get you all thinking, get you in track for answering AMC questions, right? So that is also a different art. Uh, Somebody can answer this question. You would have read the question, right? 32-year-old presents with a complaint of low back pain, having Yankee spawn for the last 5 years, being on NSAIDs, and no significant improvement. So X-ray is showing changes, right? So if I can enlarge this for you. Yeah. So again, bamboo spine. So this is the only thing you just need. You don't really need to be able to uh, identify these X-rays in detail. Just look for one point that you can. So now, if you look at this, there's actually narrowing between the vertebrae, right? So and on either side, you get these syndesmophytes on where the disc should be. There's syndesmophytes, right? So this is bamboo spine, and then when you see like this line going in the middle, that is suggestive of a fusion of the spine. So anybody in a rheumatology ward who's working would be able to like tell us better if there's somebody and somebody wants to explain the X-ray better, that would be good. But if you know these little things, this is enough, right? Just to be able to come to a diagnosis. So which is the most appropriate management, right? So he's on NSAIDs, it's not working, and he's having X-ray changes. So what do? You can't double dose some naproxen. He's already on the highest possible, 503 times a day. Again, same thing. Sulfasalazine and methotrexate are given for extra-articular manifestations. So you're going for cyclosporine is not in the treatment regime. You're going for infliximab, right? So it's another mAb therapy, right? TNF. Conditions associated with HLA-B27. So which one of the following cannot be associated? So again, you see how the question is going, which they ask you which one is not associated. So what do you think is not associated with HLA-B27? We did the seronegative arthritis. So all those seronegative arthritis was um, associated with HLA-B27 mostly. So ankylosing, psoriatic arthritis, reactive and IBD associated, right? So we know for sure ankylosing is associated. Uh, Reactive arthritis happens, I explained, if the patient has susceptibility to uh, that kind of arthritis. So they also have HLA-B27. Those people who have HLA-B27, they are prone to get this reactive arthritis after these certain infections like chlamydia, right? Or any other uh, GU infections. So that's again psoriatic arthritis. So we'll go back to the question. So what's your answer here? So these were all ankylosing is seronegative. It's HLA-B27 positive. Psoriatic is seronegative. Reactive is seronegative. So those are all HLA positive, right? Uh, we are left with anterior acute uveitis and Behçet's disease, right? So uveitis, you can say it is associated. So they're asking for an association, right? They are not saying uh, people with uveitis have HLA-B27, but it's an association. Why? Because you can get uveitis as a complication of ankylosing spondylitis, right? Or even in reactive arthritis, right? So as a result, if it's coming as a complication of this arthritis, yeah, it's associated with HLA-B27, right? So we are left with D. So HLA-B27 is found in almost 90% of patients with seronegative spondyloarthropathies. So these are the seronegative. So that's same as the slide, right? We saw. Anterior uveitis is possible finding in these arthritis, right? So it can occur secondary to those, right? So what is this Behçet's disease? Is a vasculitis of unknown origin, characterized by a triple symptom complex of there's aphthous ulcers, recurrent genital ulcers, and uveitis, right? So again, it has uveitis as well, genital and aphthous ulcers. So that is ulcers in the mouth, genital region, and then uveitis, right? They have no association with HLA-B27, right? So remember that. So here, a 67-year-old woman presents to your clinic and complains of painful hips and shoulders and headache. She relates that the muscle pain is felt in both arms and hips, so hip and shoulder girdle, right? So she feels that her shoulders are stiff and hips cannot move when she wakes up. And it takes almost 40 minutes of painful physical activity for the stiffness to relent. So that's somewhere close to their 45-minute criteria, right? Her appetite is decreased and she has lost 5 kilograms. So, weight loss, poor appetite, low grade fever, those were also features, right? To make me even more miserable, the terrible headaches has just been started, right? So, this is what she's telling the GP, right? The headache is felt on the right side, throbbing, and no response to analgesics. So again, similar situation. They're giving you a patient with polymyalgia rheumatica. Now she's coming with headache. Any polymyalgia rheumatica background coming with headache, you need to think of giant cell arteritis because it's it's an emergency, right? Which needs and it's actually reversible in the sense you can stop the progression into permanent blindness by giving high dose of steroids. But if you fail in administering the steroids, it can lead to irreversible blindness, right? So that's why it's considered an emergency, and anyone complaining of a headache, you have to think of giant cell arteritis, right? On physical examination, noted to have painful restricted movements of the shoulder and hip joints. Her right temple is tender to touch, right? So, right temple is tender to touch. She is not febrile. Rest of the exam is incomplete. Which of the following is the most appropriate next step in management? So, what is your next step? So, you need to first confirm this diagnosis, right? So, you have to go for an ESR, and they generally have a three-figure ESR, right? So, three-figure ESR with headache means you need to administer prednisolone, high dose, right? So, which one of the following is recognized as a feature of PMR? So, somebody answer this. Go by the exclusion method and try to see if you can answer that. Otherwise, somebody just tell me yes or no. Is it weakness of the distal muscle groups? We've been doing PMR since the beginning, so you should be able to answer this faster. What is it? Is it distal muscle groups or proximal muscle groups that are affected in polymyalgia rheumatica? Come on. Just go with the exclusion method. Okay, so polymyalgia rheumatica weaknesses. I mean, if you just think about it, you can answer that. We are talking about shoulder and hip, right? So shoulder means proximal muscles, right? And hip means again proximal muscles of the lower limb, right? So proximal muscles of the upper limb and proximal muscles of the lower limb. So this is not the answer. Then elevated CPK or CK, like I said, it is elevated only when the muscle is inflamed, that is in myositis. So anything ending with myositis, polymyositis, dermatomyositis, statin or drug-induced myositis, right? So here we have a normal level of CK, right? Associated with bronchial carcinoma. So there was no such association mentioned with regards to polymyalgia rheumatica. So when we go through the associations. If you mention. That was only for polymyositis, right? Yeah, so that was polymyositis, right? So more likely to be an associated cancer with dermatomyositis, polymyositis also. You can have lung cancer, breast cancer, right? But that was not with uh, polymyalgia rheumatica, right? Uh, Peak incidences, fourth decade means in their 30s now. So ideally it's about 50 years and above, right? So it's in the sixth decade of life, right? So our answer is weight loss. So you see, weight loss seems like a very unlikely answer here. Like it seems too simple, too vague, right? When to choose this answer, right? But then when you go through that exclusion, you will be left only with weight loss, right? So you can easily exclude these things from the theory we have done, right? Oh. So we go by this 43-year-old woman complains of uh, increase increase in sensation of foreign bodies in her eyes. Her eyes are itching and dry mouth for the past 6 months. So she also reveals that she has recently developed dry cough and pain of the hand joints. So here, sensation of foreign body in the eye means uh, dry eyes, right? So dry eyes and then dry mouth. So xerophthalmia, right? And then she has a dry cough and pain in the joints of the hands. So there's bilateral swelling of the parotid glands and the metacarpophalangeal joints and the proximal interphalangeals are tender to touch but not warm or swollen, right? So that is sort of a rheumatoid arthritis like picture, right? So if you remember that diagram where each arthritis you had the joints, which joints were involved, so this is giving a rheumatoid sort of picture, right? She denies any morning stiffness, so she doesn't have any inflammatory features, no morning stiffness. Serological tests are significant for positive ANA and rheumatoid factor, however, right? So if rheumatoid factor is positive, you're thinking of rheumatoid picture. And then on the background of that, you're having this dry eye and dry mouth, right? ESR and CRP are elevated. Urine analysis is normal. Which one is the most likely diagnosis, right? So again, when you take SLE, they wouldn't give you a positive rheumatoid factor, right? Bulimia nervosa, there is no nothing to suggest it's a bulimia, right? You get enlarged parotid glands in bulimia, but they are not giving you any other features. So that's out. Again, mumps, you get enlarged parotid glands, but you will have an associated fever, right? And then UVA parotyte fever, it itself says fever, right? So they're not giving us a fever here, right? Uh, and dry eye, dry mouth. Wow, I told you all if they're talking about dry eyes and dry mouth, it's always Sjogren's syndrome, right? Didn't I do Sjogren's syndrome? Okay, it should be somewhere I just go through the slides slowly and see. I have entered Sjogren's syndrome somewhere here. I cannot find it right now. So, with Sjogren's syndrome, or maybe I think I just showed it to you all as a separate thing, no? So, the way to remember I was telling you with Sjogren's syndrome is the letter O in Sjogren's has two dots above it, right? So just looking at like in this, you have two dots above the letter O, right? So this looks like two eyes and a mouth. That's how you remember it, right? So this looks like two eyes and a mouth. So that is, you think of it when you, the moment you see this name, two eyes and a mouth means dry eyes, dry mouth, right? So Sjogren's syndrome is dry eyes, dry mouth, and then it has, it is associated with other things, right? If you remember the previous slides we did in the lecture, it's associated with rheumatoid arthritis, right? Raynaud's syndrome, all of these are, all of these come together, right? So here they're talking about Sjogren's syndrome, right? And Sjogren's syndrome, generally you can do a biopsy of the salivary glands. I think I don't know why I cannot find that slide. It was all in one picture. See if was it this? Okay, yeah, sorry. So here, dry eyes, dry mouth. Uh, these are the usual manifestations that are associated with these rheumatoid diseases, right? So you can get peripheral neuropathies, Raynaud's phenomenon, vaginal dryness, digestive problems, lung, bronchitis, pleurisy, because again of the dryness, so they have a problem with the secretions, right? Uh, Secondary Sjogren's syndrome, if you take, it's this is what they're talking about in that question, right? So salivary lacrimal gland dysfunction in the setting of another connective tissue disease such as SLE, rheumatoid. So rheumatoid factor was positive, yeah. Scleroderma, polymyositis, primary biliary cirrhosis. So this is the background in which Sjogren's syndrome can be associated with, right? So you can also get a primary one where that's the only thing you can see. Otherwise, you can get it associated, just like how they were showing PMR with giant cell arteritis. This is another association they're talking about, right? So again, 66-year-old man. So salivary gland biopsy is the confirmatory diagnosis, right? 66-year-old man presents to your practice with complaints of left-sided cheek swelling, joint pain, and fatigue for the past 2 months, right? He has a 20-year history of type 2 DM and mentions eye and mouth dryness for the past 6 months. On examination, non-tender swelling of the left parotid gland and several dental caries and reddened eyes. Which one of these is the most likely diagnosis, right? Oh. So again, dry eyes, dry mouth, right? So you're thinking of Sjogren's syndrome here, right? So if it's Behçet's, you'll have that whole triad, right? We don't have the triad here. With this patient, right? Chronic parotiditis, uh, again, it will be tender. Salivary duct stone is going to be tender. If it's a carcinoma, they will give you other features like weight loss and all of that. And the history would be much longer, right? Otherwise, it could be like the parotid gland is growing in size, so there'll be so many other features associated. Then 64-year-old man, just I'm not going to the other slides anymore. So, 64-year-old man who has hypertension type 2 DM presents at the emergency department with a hot, swollen, erythematous right knee, which he says is too painful to bend, right? So, hot, swollen, erythematous, too painful to bend. So, you're thinking about it could be even a septic, right? And he takes several medications: thiazide, ramipril, metformin, sitagliptin, and his right knee is swollen and erythematous. He has psoriasis affecting the scalp. So again, they are trying to make you think about psoriatic arthritis as well, right? Both CRP and serum creatinine are raised. So what is the most likely diagnosis? Sorry. So here they've given us an X-ray. So this is the very same X-ray they gave at the exam as well. I think we discussed this on the first day in the introductory lecture as well. So here, this is called chondrocalcinosis, calcification or deposits within the articular cartilage, right? So this sort of fluffy exudates you see between the joint, you don't see it in gout, right? You see this only in pseudogout. So chondrocalcinosis is there only in pseudogout, right? So here they're giving you a picture. You're not sure when you're reading the question. It could be a septic arthritis when they are talking about it, and since it's a knee joint, right? Then again they're giving certain drugs he's on that will make you think of other stuff. Then psoriasis, it could be a psoriatic arthritis you're thinking of, right? But when they give the x-ray, so obviously when you have this kind of picture, you're thinking of pseudogout, right? So gout will have other tophi, you'll be able to see the tophi, the soft tissue enlargements and all of that. So pseudogout is known as calcium pyrophosphate crystal disease caused by calcium crystals. And when these crystals occur in joints, they can create intense pain, redness, warmth, and swelling. So again, similar picture to septic arthritis without the fever, right? Knee is most commonly affected, but it also occurs in other large joints such as hips, ankles, wrists, elbows, and shoulders. So it can your question will come from any joint, right? Gout and pseudogout has similar symptoms, but the causes and treatments are different. So you need to read up on that also if you want to just. We did the. So this is a bit on the pseudogout, right? So this is the calcium pyrophosphate crystals. They are found in the synovial fluid, the synovial lining, and the articular cartilage. So this is why you get that fluffy sort of exudates, right? So this is what we just saw on the slide. Uh, just go through this. So if you notice that question, they gave you a patient with all of these conditions: high blood pressure, diabetes, right? Taking diuretics. So they were actually making you think of gout initially, right? And then when they gave you the x-ray, it's the other way around, right? So here, just know this, gout means negative birefringence, needle shaped. Pseudogout was positive birefringence, rhomboid shaped, right? Is there are questions where they have given you the aspirate findings and then asked you to come to the diagnosis, right? So here again, white lines of chondrocalcinosis, and here you get these erosions actually with gout, right? So you get, and the joint is sort of destroyed in gout, and you can see the tophi sometimes on either side, the soft tissue nodules, right? So that's about it. Uh, I hope that was helpful, and y'all can message me or put on the group or anything if there's any feedback that you want to give. Uh, and hopefully from the next session, I think we are going ahead with cardiology. They'll let you know. We'll try to somehow complete the syllabus before the February exams. We might need to do some extra classes as well. But of course, if you guys are sitting the exam, you will have to make time for study. And also, we'll be arranging at least two mock exams prior to the main February sitting, right? So it depends on from our group who's going to be sitting the exam first, right? I think February 9th is when the exams start. So if anyone is doing on the 9th, we will put everything before the 9th. And then it depends on who is doing the exam first, right? So we'll have the mock exams before that. And then exam week, also we will be in touch with y'all. Y'all can get support from us if y'all have any questions, new questions that are coming up, and y'all want us to look for answers, find the guidelines. We'll be helping y'all with that, right? So, and constantly y'all can share your stuff on the WhatsApp group, uh, and keep yourselves updated. So that will really help you study, right? So thank you then. Just give us a feedback, right? Good night.